image guidance now has secured a very stable place in the intervention in our country also. And that's a good news. So today I am going to speak on image guided PCI. I have created the talk as a case based presentation where, many times we have been successful, a few times we have failed, and the reasons of success and failure and how imaging helped us identifying the complication, even reaching the success, etc. So the first case was a 68-year-old male, diabetic, hypertensive, hypothyroid, and inferior wall MI, history of inferior wall MI before 6 years, presented with class 2 angina on medical management, mild LV dysfunction. It's not moving, the slide. Okay, yeah, it's moving here. Okay, it's not moving here. So it looks a very simple lesion. But here, I had problem with a regular wire, extra floppy run through, and I struggled even with balloon. It was simply not entering. And ultimately, I had to use pilot 50, and with a 1.5 balloon, I could cross. It looks very simple. But when you see after pre-dilatation, when I did optical coherence tomography, this was the picture. It is a recanalized thrombus, very old chronic recanalized thrombus with a honeycomb appearance. So then we fixed it. This is the picture. We fixed it, and then OCT and the angiographic result was perfectly clean. So sometimes, you have to think of it, 6-year or a very old MI and presenting with like patient presenting with like simple lesion can be a functional chronic total occlusion. Another case is a 59-year-old man, diabetic, hypertensive. PCI of LAD was done before 4 years and presented with anterior wall MI to us with a severe left ventricular dysfunction. It was an interesting angiographic view, and we thought that it could be a spontaneous coronary dissection. Because what else? It looks like a flap. The stent is in the proximal LAD, and it looks a very awkward. There is some ectasia there. And we worked on it. It looks very simple at this point of time. We did left main to LAD and then kissing balloon and a perfect result. But then half an hour we spent perspiring and thinking what is going wrong. This was the picture. When we did it, initially the wire went through the strut in the main artery, and then we had to correct the wire, going through the proper channels. Now we did it properly with kissing balloon and everything. Interestingly, we did both OCT and IVUS image here. This is an OCT image. Just focus here on the shaft. It is now in the different channel, and now it is coming in the left main. There was an aneurysm which happened at that point of time in the edge of the stent, in the proximal edge of the stent. We confirmed even with IVUS here. This is a true lumen. And now suddenly you see the shift of the shaft into a different cavity. And this is the original cavity. And then again coming, you can see the left main. So this happened. And these are the still pictures which we clearly show the lumen, the aneurysm, the shaft was going through, and then the correction was given, and this was a perfect picture. So these are the problems, you can identify. Otherwise, without imaging, you remain clueless and you don't know what you are doing. A very interesting case, a 25-year-old female presented with ACS, ECG is showing inferior wall STT changes, raised troponin, a selective coronary angiogram, giant aneurysm. And we did MRI of the brain vessels, abdominal, just to rule out Kawasaki type of phenomenon, whatever. And she had moved around everywhere. Everywhere the surgery was advised. She was 25 and ready to marry after 1 year. She came with the fiance and the parents. And see, this is what it is, impending and rupture, aneurysm, huge aneurysm with impending rupture. There must be a good amount of clot inside too. When we measured the size of aneurysm, it was almost like 29-30 millimeters. And the papyrus stent, longest stent available was 26. What to do? We thought over it. Okay, you cannot overlap two covered stents. We gave the option of covered stent under image guidance. You know, inside this cavity, which is a very unstable type of aneurysm, here my colleague Sanjay came out with a brilliant idea. We created a platform with a metal stent, 38 millimeter Giants expedition measured, 38 millimeter Giants expedition stent was deployed, stented the region, and then overlapping two papyrus stents were deployed one after the another. You can see this is the another papyrus, and the aneurysm is gone. We checked it with OCT guidance. This is how we worked on it. We checked it using the OCT guidance. You can see the perfect deployment. The aneurysmal cavity collapsed because, blood flow stopped going there. And you can see all the blood collection all around the site of the aneurysm. And you can even see the overlapping of the stents. This is how it looked, at the normal segment of the Giants expedition and inside the aneurysm. We called her back again after 9 months, and you can see the perfect result. We even did OCT guidance at that point of time. And you can see the perfect result. There was some proliferation at the overlapping site, absolutely acceptable. There you see some proliferation only at that site, and then again the normal segment. Patient is doing fine. It is almost 3 years. So this is one way, because otherwise we had no choice but to give her a graft on the right artery, and which was pretty not acceptable for them. This is a 60-year-old female, hypertensive diabetic, presented with recent inferior wall MI history and mild left ventricular dysfunction. PCI to RCA lesion was planned. And see what happened. First injection, and there is a spiral dissection. Through and through, going right up to the PDA, and just at the lesion site. Complete plan was changed. Now we wanted to dilate, stand, do proper image guidance to see everything is fine. Instead, first worry was to prevent the extension of this dissection in the ascending aorta, because if it extends, it will go up to innominate and it can create disaster. So we changed our strategy. We fixed the ostium first. And once we fixed the ostium, of course, there were a lot of issues. Patient had pain, hypotension, everything. We deployed another 2 stents and reconstructed the artery. It looks pretty good, and in different views we checked. We didn't compromise any of the major branches. And you can see the optical coherence tomography image. It is very acceptable, with some areas of intramural hematoma happening, beyond the dissection area, but perfectly acceptable result, and patient remains stable. Dissection and hematoma, we are using IVUS and OCT, but in this particular situation, many times we get a better, more information with the OCT guidance, which is a very regular affair in our lab in almost 50% of coronary intervention. We have an investigator-initiated IOPUS trial where simultaneous IVUS and OCT imaging have been done for the same lesion, and you can see This is how it looks in IVUS. This is how it looks in OCT. Dissection and hematoma looking in IVUS and OCT. Another image. A huge hematoma there, which looks like this. In OCT, if the artery is very big, sometimes, you can misinterpret this hematoma. In IVUS, it looks better in the bigger arteries. And another example. Another case of a 68-year-old man, hypertensive diabetic, class 3 angina, fair LV function, left main bifurcation Medina 111, syntax score 18, mini KRISH of LMCA lesion, bifurcation was planned. This was, in the beginning when we got a new software of the OCT, that is before 3 years, I suppose, or 4 years. And it was done in a perfect copybook style case, mini KRISH. Everything was done as per the book, LAD to LMCA OCT run. And this is how the circumflex looked. Distal crossing was done, again dilated, and then circ to left main run and LAD to LMCA run. Perfect result. And this is what you see as a result, end result. Another case, this was a 66-year-old male, class 3 angina, hypertensive diabetic, angiography, left main trifurcation. Of course, if you consider bifurcation, Medina 111, high syntax score, patient refused surgery, and we accepted for intervention. Here, rather than creating crowding around the area of carina, we have used the technique, mini KRISH, and for time being, we became selectively blind to the ramus intermedius. Because it is extremely tight lesion there, we presume that there is a good amount of ischemic preconditioning. Even if it occludes, we will see what happens. And then we worked on it, kissing a mini KRISH, kissing balloon, and perfect result. And the ramus is flowing as it is. And this is how it looked in the OCT. You can see the perfect result. And we have now almost the data of more than 200 left main bifurcation done under OCT guidance. And I'll show you the original, the standard teaching is, you have to identify whether, you have to see two things, link free carina or link connecting carina, and distal crossing or proximal crossing. Standard Japanese teaching, because Japanese have done the maximum work on it, is link connecting or link free carina is not in the hands of the operator, whatever you do. But proximal and distal crossing, you can always think of. And they say that more you do distal crossing, you get a better cosmetic result. And of course, MACE and TLR rates are also low. But in our experience now, with almost 30 months of median follow-up of about 200 left main bifurcation OCT guided cases, we have stopped doing proximal distal crossing, and we are doing it exactly the way, the kissing and all those things. And we have not found any sort of major problem as far as the MACE and TLR is concerned. That publication, we are going to write on it, and you will see that publication down the line. This was the original traditional teaching, but we are now not thinking of proximal or distal crossing, and we are working, in a normal fashion. This was a 49-year-old male diabetic hypertensive presented with angiostomy, normal ventricular function, and angiogram revealed a tight 90% ostial left main lesion. Of course, we always use intravascular ultrasound for this, and here, we tackled it properly. This is the end result, which looks perfect. But when we did the post-stenting IVUS run, this is what we saw. Despite a very clean angiographic result, there was a damage to the struts of the stent which are protruding outside, and that has created a quite oblong type of lumen, which was corrected with post-dilatation, and this is how we got 11.44 minimum stent area, which is the perfect result. Another case of 65-year-old male hypertensive diabetic presented with a very high CT calcium score in the left main region with a normal ventricular function. And you can see a tight ostial left main. We went ahead to stent the left main ostium under IVA's guidance. But to our surprise, you can see there is a good amount of calcium. Of course, the lumen does not look absolutely circular, but minimal lumen area is 10.26. So we deferred the intervention. A 55-year-old male, diabetic, hypertensive, hyperlipidemia, NSTEMI, raised trop, class 3 angina, fair LV function presented to us. And this was actually, in another country when I was giving a live demonstration in the national conference. And we had available in our armamentarium IVAS, OCT, and rotational atherectomy. We rotablated this lesion. What should be the strategy? Strategy was we rotablated this lesion. We did optical coherence tomography dilatation run after post dilatation after rota. We thought that everything looks good. Here we got stuck. And this is what after stenting we see. It looks very scary. Why it happened? Because the time slot was 35 minutes to finish my case, and I hurriedly interpreted the optical coherence tomography image in the proximal area. I thought everything has been totally, it looks perfect. And then the rotablator, optical coherence tomography catheter was simply refusing to go inside. And I had to use IVAS catheter, which has a better muscle, and I could cross it. And here you see there was a nodule which I missed. And that created problem. There was a hematoma, and the minimal stent area was very, very low in the very proximal LAD, 4.51. Fortunately, to my fortune, the nodule was towards the diagonal side of ostial LAD, and I could significantly dilate it to make it 5.5. And this retrospectively, when I interpreted the IVAS or OCT image, this is what happened. The message is, if you are doing imaging, spend good time to interpret it. Otherwise, you can create problem for yourself. Dilatation and then the satisfactory result. One more case is a 67-year-old male hypertensive diabetic, class 3 angina, mild LV dysfunction, and this was post-bypass case. You can see, whenever I see this type of picture on angiogram, particularly in a post-bypass, long duration bypass case, without imaging, now I can at least predict that I have to encounter a very bad nodule in that region, calcific nodule. And then we try to initially break with the non-compliant balloon at a very high pressure, because here, sometimes giving a rotablator or whatever, at that time, of course, orbital atherectomy was not available. So we dilated. It is a very bad nodule there. You can see spiked nodule. 2 or 3 balloons ruptured, but we were able to break a lot of calcium at and around nodule, but we could not get the best of the result here. And we, from 3.17, we could create a 6.88 lumen, which was acceptable. Of course, it was not very nice to see, but here I have to hold in the interest of the patient, because if you try further, you can create 2 problems. Number 1, you can perforate the artery, and if not, then you do a stent fracture. If you do stent fracture, it is very, very significantly high chance of patient coming back with the restenosis or acute initial problem. And if you perforate, you are creating problem for the patient. So this is another case which was taken in IOPUS investigator initiated. These are the nodules with a spike, which are malignant nodules. And here normally the balloons don't work. You have to rupture the balloon, you have to damage the vessel in the surrounding, so you have to be careful. Even the lithotripsy does not work in this type of situation when the surrounding area is good and this type of nodule is there. With a limited experience of several cases we have done with orbital atherectomy, this is where orbital atherectomy helps because of its mechanism of moving around at the axis. It can, ablate and make it little more blunter for the balloon to open it up. And this is what, this is one case where you see the calcific nodule, spiked nodule there. It looks like a spiked nodule. And this is what you see on optical coherence tomography, a sharp nodule with a sharp edge there, and orbital atherectomy. And you can see a good amount of ablation there, and you can see the result was perfect after dilatation. And this is how it looks. Another similar case, you can see high CT calcium score. Here is a shelf lesion, which is a shelf-like lesion. At times you feel, if it occupies the whole area, you feel it is a membrane. But this, I was pretty sure that I am dealing with a sharp calcific nodule. Again, orbital atherectomy. This is what it looked, in OCT image, which we did before going for orbital atherectomy. Ablation done with orbital atherectomy, ballooned, and you can see how it was broken, and then with stenting you can get a perfect result there. And this is how it looked, and this is how you achieve the end result. So what is the importance of calcium plate fracture? Again, a seminal, small but beautifully done study. Initially, the score was given by Fujino and Mahara, the calcium score, OCT calcium score, 1, 2, 3, 4, according to the amount of calcium less than 90, circumference less than 90, 90 to 180 and more than 180. 90 to 180 is 1, more than 180 is 2. And then the length of the calcium, more than 5 millimeter is 1, about 5 millimeter or more is 1, and the thickness, more than 500 microgram is 1. 1 and 2 means you can break the calcium with balloon, non-compliant balloon. 3 and 4, you have to use the technology. It could be rotational atherectomy, it could be orbital atherectomy, it could be intracoronary lithotripsy, or it could be cutting balloon, whatever. And then you have to break the plates. Why? What is the importance of calcium plate fracture? Again, a beautiful study by Akasaka et al. Most of the OCT initial seminal work has been done by Dr. Takashi Akasaka from Japan, a thinker and an innovator. A calcium plate thickness less than 500 micron was corresponding to cutoff value of predicting calcium plate fracture by high pressure ballooning without using any technology. So what does it mean? You can see how does it transform in clinical practice. Minimal stent area with a fractured calcium plate is higher as compared to non-fractured calcium plate, and stent expansion index is higher in calcium fractured plate as compared to non-calcium fractured plate. So how does it matter in clinical practice? It has a direct impact on the long-term result. Binary restenosis 14% vis-a-vis 41%, and target lesion revascularization 7% vis-a-vis 28%. Significant difference. So use imaging in any calcified lesion. And here IVAS has scored over many situations over OCT, but many situations OCT is better, so they are complementary. We have a preference for OCT for most of the cases. Here OCT will help you because you can create, you can calculate the calcium score, and accordingly you can decide your strategy and you don't overuse the technology. and you use the technology whenever it is appropriate. So lesion modification should be attempted to reduce the calcium thickness if it is more than 500 micron, and try to reduce calcium thickness to less than 500, whatever technology you are comfortable with. More the calcium fracture, better it is always. And these are few examples. You can see 360 degree calcium, around 90 degree, more than 180 degree calcium. Here, high pressure ballooning leading to calcium fracture plate. Again, high pressure ballooning leading to calcium fracture plate. Rotational atherectomy will give you this sort of pulverized type of calcium disruption, and then you can break it with the balloon. Here, rota followed by high pressure balloon. You can see big sort of blocks of calcium once you have done the rota. Rota followed by high pressure balloon. Again, you can see many calcium blocks once you have done the rota. Rota followed by high pressure balloon. Baseline is like this. This is lithotripsy. Again, lithotripsy, sometimes you may or may not be able to appreciate the calcium fracture, but once you dilate with the balloon, and ultimately when you stent, you get an excellent minimal stent area. Only caution is, like if there is a calcific nodule and if the surrounding area is reasonably good or fibrous or non-calcified or normal, then lithotripsy, you are going to waste lot of pulses, and particular area it will not work so well, particularly in isolated, discrete, bad calcific nodule. Again, this is an example of the same baseline, shock wave, final. This is another example, shock wave, high pressure balloon, and final MSA. So the value of experience is not seeing much, but saying it wisely. Thank you very much for your kind. Thank you, sir.